Greetings, this is Dr. Dave on behalf of Healthy But Whole, and today we're going to be talking about the nitrates, so isosorbide mononitrate and isosorbide dinitrate. The content that we're going to go over is first the pharmacodynamic effects, so what the drug does to the body, then the pharmacokinetic effects, so what the body does to the drug, so ADME. Then we're going to go in through a brief hydralazine interlude and then talk about some considerations in use and the indications and the lack of indicatins. So looking at the pharmacodynamics, specifically the mechanism, a nitrate is going to induce relaxation of these vascular smooth muscles and cause dilation. The effect is greater in the veins than the arteries. So in the veins, dilation is going to lead to a reduction in preload. This can be seen as a reduction in the left ventricular end diastolic pressure and also a reduction in the wedge pressure. The arterial dilation will lead to a reduction in the afterload, which is seen as a decreased systemic vascular response and mean arterial pressure. This image is from an AHA journal, not super relevant, but he's in a lot of pain and I feel bad for him. Pharmacodynamics, looking at the dosing, so for mononitrate you're going to start at a 20 milligram dose 2 times a day, 7 hours apart. You may initiate at 5 milligrams a day and titrate up towards 10 after 2 or 3 days. If you're worried they're frail, may have an issue tolerating it. Doses greater than that 20 milligrams twice a day have not been adequately studied, so hopefully not something you're seeing too often in your practice. The extended release, you would start with a dose between 30 and 60 milligrams every morning and titrate up based on a response, maximum dose of 240. The dinitrate, so immediate release, we're looking at 5 to 20 milligrams by mouth twice a day to 3 times a day. The 3 times a day is what's more common. So you start with this initial trial dose, again, see if they tolerate it, go up to this 10 to 40 BID to TID. And this part that I've highlighted in red is unique to the dinitrate indication, not necessarily what you would worry about in practice, but just the dosing indication. They include the importance of a dose-free interval. So at least 14 hours to minimize tolerance. I would also say to minimize risk of treatment. The extended release is a 40 milligrams by mouth, and notice that this dose-free interval is now 18 hours. So more worried about, if I miss my dose 6 hours ago, do I just take another? No, probably not. Sustained release, 40 milligrams, dose max of 18 hours, and a maximum daily dose of 160 milligrams daily. I put micromedics up here because this is straight off micromedics. Do not sue me. I do not have money. So looking at the adverse effects, so the adverse effects of the mononitrate, we see dizziness in 8 to 11% of patients. In the ER form, less or so in the IR form. Headaches at 38 to 57% in the ER form, and 13 to 35% in the IR form. If you've ever looked through micromedics and you're looking at adverse effects of medications, I challenge you to find any that have incidence rates that are these high. That's insane. That 1 out of 2 people is going to have headaches, 1 out of 10 is going to become dizzy. Not great data. The cardiovascular effects, so heart attacks, incidence rates in the IR of less than 1%, bradyarrhythmia, so slow heart rates in less than 5, chest pain, immediate release less than 2, heart failure in the extended release less than 5, hemorrhage less than 1, and there's no black box warnings. That is the same for dinitrate. Dinitrate, a lot of the same side effects, but I could not find incidence rates as I have them here for the mononitrates. However, I don't think that means that there is less of them. It is just that I only looked through micromedics, and I noted here that I will check other sources, and I didn't. On to the next one. So, pharmacokinetics. We got a mononitrate and a dinitrate. Images are from PubChem. As you can see, these differ massively in their chemical structure. This alcohol group here is changed by a tertiary amine. Pharmacokinetics, mononitrate versus dinitrate, the absorption, pretty similar. Immediate release, we're going to get a maximum effect in an hour, plus or minus 30 minutes. Extended release 3 to 4, 3 to 4. You do see a lot better of a bioavailability in the mononitrate than the dinitrate. Volume distribution 0.6 liters versus 2 to 4. Both have pretty minimal plasma protein binding, both hepatic metabolites. However, the dinitrate has extensive first pass, which is why we see the super low bioavailability. Excretion, half-life, same thing. So 5 hours, 5 hours. Real difference is just that bioavailability and the fact that this undergoes the first pass metabolism, which is in direct relation to that extra nitrate. So going on, what we're going to talk about next is the duration of effects and their specific indications. So the mononitrate lasts for 6 to 10 hours, and the dinitrate, so there's a sublingual form, oral IR, and those sustained release. So sublingual can be as rapid as 10 to 60 minutes, by mouth 4 to 6 hours, or if it's a sustained release, 6 to 10 hours. Important indication notes for both of these, okay? So first, for mononitrate, it is indicated for esophageal varices, stable angina / prophylaxis. The indications for dinitrate, it is indicated in heart failure. So, active anginal episodes and prevention of angina. I do also want to note that when we looked here at these dosing-free intervals, we have dosing-free intervals clearly defined in the dinitrate, not in the mononitrate. If you have a highly keen physician and everybody's understanding and you counsel your patients correct, hopefully you're not forgetting that part. But, I think not having these dosing-free intervals puts the patient at risk for inappropriately using the medication and risking Monday disease, which is the symptomatology of nitrate tolerance. And we're on to the next part, which is our hydralazine interlude. So the mechanism, it's one of those that has the wonderful sentence right at the start that there's a lot of unknown effects. However, the most known effects, and again, these are all from micromedics, is antihypertensive effects through dilation of veins, a dose-dependent inotropic effect at actions in the calcium channels, so it can either be a positive or a negative inotrope, an indirect increase of renin. Dosing is 25 to 50 milligrams, 3 to 4 times daily. Common side effects, I've listed them there. I did note polycythemia, mostly because I didn't know what polycythemia was. I had to look it up as the opposite of pancytopenia, where all of your different types of blood cells are getting destroyed. Most of them are increasing. So it's particular ANCs and WBCs, so the white blood cells and the absolute neutrophil counts are going up in this one. Half-life, 3 hours up to 7. Plasma protein binding, 87%. Here's its chemical structure. I have no idea what that means. Considerations and use. So there is an AHEF trial which established the efficacy of nitrates and hydralazine for heart failure in Black patients. So if we go back up to the indications, that is this. That is why I've mentioned that dinitrate is used in heart failure and then threw in hydralazine. This is a trial that brought hydralazine and isosorbide into more common practice for Black patients with heart failure. But this trial was a descendant of the VHEFT series of heart failure trials. These trials, just to summarize in a couple sentences where I didn't actually read those trials, is that they were looking at different treatments and the progression of heart failure. They saw a subgroup analysis which indicated that Black patients were benefiting from isosorbide mononitrate, nope, I said it wrong, dinitrate, and hydralazine, whereas no other populations were, and they said that's really promising. So they conducted the AHEF trial to further investigate that relationship and establish this potential for positive effect. The only other population which is using nitrates on a chronic and scheduled manner is those with unstable angina, right? If we're looking at the indications of these treatments, you should not walk into little Mima's room and have her taking a nitrate every day without a history of angina, varices, heart failure. It's things that should really pop out at you, right? It's not the world's most common med, and there's obvious reasons why, right? 2 to 3 times a day, and a lot of these side effects. Remember when we went over the fact that 1 in 2 patients is going to have a headache, 1 in 10 patients is going to get dizzy. It's pretty hardcore. And so after the considerations and use, I want to talk about something entirely spookier. This was written while I was in the middle of conspiracy binges. However, I want to talk about it because I think it is interesting that IMDR, being isosorbide dinitrate, and hydralazine remains in clinical guidelines based on what I'm about to discuss. I do want to note before I say anything is I think the authors had an entirely positive intention towards the treatment of patients and the conduction of the trial. It's just some logical concerns when you look at the data. So my concern specifically about AHEFT is that there's interviews on YouTube where an author goes into a lot of depth about this gene, in particular the GBN3 gene. Just like, oh, we're seeing it's more upregulated in Black patients, and it has all of these downstream effects. And I like gene talk, but I don't really understand it. So if you want to give me more context to that or literature, if I look up the GBN3 gene now, I'm seeing hundreds of studies, and not a lot of them are racially oriented. So this gene, nor genetics at all, were not mentioned in the trial. Do note that this does not include a review of all supplementary material, and it is my eyes, so I could totally have missed things where they allude to this gene. If I did, let me know. The author also notes a need to conduct the analysis in a clinical trial which meets standards for approval in guidelines and regulations. It was hard for me to understand if this came out before they actually started doing AHEF, because the way it's written makes it sound like a clinical trial, because there was first extrapolations made from VHEF where they thought they could influence clinical trials. Just looking back at the cohort they already had, right? They saw that these Black patients benefited. Can we just say, boom, we already did the trial? There wasn't enough data to support that, so they did AHEF. The study also compares a combination of two very strong antihypertensives against placebo. We know all sorts of data about the benefit of dropping somebody's blood pressure, especially if they're hypertensive. So I think that's a huge confounding variable. They also excluded all acute coronary syndrome patients, recent strokes, scheduled to be in cardiac surgery, presence of valvular disease. And so what are the concerns 15 years later? The isosorbide dinitrate and hydralazine is so dated now compared to most of this GDMT, which we've seen coming out, since 2015. So I would always just make sure that, these aren't frontline. There's a lot of iffies and whaties going on upstream, and the new data is very strong. I also want to note that the fixed dose, so IMDR in particular, has been shown to be superior to off-label combinations of nitrates. So any other combination of isosorbide, mononitrate, dinitrate, and hydralazine that is not a fixed dose combination and is when used at prescribed dosing of BID to TID. If we're seeing that there's only a positive effect in this particular product, it should be a fixed dose. And on top of that, if a patient's not able to take a BID to TID medication, really worry about keeping this as a front line of their therapy because it might not be doing any sort of benefit. I know that BID to TID dosing is almost impossible for many patients to manage at home. So just always keep that in the back of your mind about, is this person compatible with nitrates? But just looking at the physiological effects of these nitrates with newer technology, and they don't see that there's any benefit in decreasing cardiac remodeling, the symptomatology of heart failure, right? Because these were patients with heart failure. And it is poorly tolerated, right? It's because all of those things we talked about, the dizziness, the headaches, it goes on and on and on with these drugs. So a summary of this is that it hasn't been compared to GDMT. It needs to be used at that fixed dose combination, which is really hard to get most patients on. And preclinical data has not shown that there is this massive benefit to the underlying cardiac model, albeit a very small population. So not things I would make claims about, but just concerns, right? There's not any studies assessing these nitrates and if they're truly still appropriate. You'll see that I have a bunch of references throughout my talk today. These are the different sites and literatures and everything else you can look at. And I encourage you to do so or ask me a question. But for now, I'll stop blabbering on. It's been Pharm Dave, and this is Healthy But Whole.